And last but not least, we'll move into Dr. Rakesh Ahuja. He is an adult and pediatric vascular and interventional physician. He did medical school at KJ Samoya Medical College in India. And before coming to the US, he completed a surgical residency at Rajawandi Government Hospital in India, and then came to the US and finished his surgical residency at UCLA and Albert Einstein, and then did integrated IR residency at Albert Einstein, as well as a fellowship in pediatric interventions at Boston's Children's Hospital. And his clinical focus is vascular malformations.
So again, keeping up with the theme, we're not going to talk about a venous malformation, lymphatic malformation, AVM, this, blah, blah, blah. These are the diseases of vessels. So we call them vascular anomalies. That's how we're going to start this, okay? So starting with the landmark paper where Dr. Mulliken and Dr. Glowacki in 1982 were able to describe all of these and sum them up in different categories, tumors, malformations. That's what they started calling them. Then the further down the lane, this is a very specific niche kind of disease processes. So there needed to be some sort of like classification system. So ISWA was developed, which is the International Society of Study of Vascular Anomalies. The first classification came in 96, and 2018 is the most recent revision. And you can always go on the website, and there is a PDF where descriptions keep changing, but those are the most up-to-date ones. So they're defined into tumors, which can be benign, locally aggressive, or malignant. And then there's malformations, which can be simple, combined anomalies of the major named vessels, and which are associated with other anomalies, which could be mixed like CM, VM, LM. There is a potpourri of names. We call them syndromes, which is Klippel-Trenaunys, Parkes-Weber's, and Cloves. You will see the name change. It's not high and low flow anymore. It's slow flow and fast flow. The reason the names are being changed, and this is coming from the horse's mouth, which is Dr. Mulliken, who I worked with at Boston Children's, is because when you call this as high flow, the high flow basically can be confusing in a way that it could be high resistance flow or high flow because there is low resistance. So to avoid that confusion, it was just named as slow and fast flow, which will come in the newer classification systems. So basically, the gist of the idea is when you have slow flow, sclerotherapy is the basis of the treatment. Fast flow embolization is the basis of the treatment. How you do it, depends on what kind of disease are you dealing with. So some case tips. Fluid sensitive sequences are your best friend. Even if you don't have contrast enhanced studies, that's fine. You can still find out what's going on majority of the time. About more than 90% of the time, you're going to be fine without contrast. T2, especially the fat saturated sequences. Stir sequences are amazing, believe me or not, but sometimes all we see is T2 and stir, and that's it. We're done. Don't underestimate the power of ultrasound, especially if you are doing it, especially if it's in your hands. Trust yourself. Ultrasound is the huge tool that we have. Have skepticism towards the referring diagnosis because this is such a niche disease. Majority of the patients present with the wrong diagnosis. Almost surprisingly, over 90% present with wrong diagnosis. Be respectful, trust your read, and see the patient and/or the photos if possible. Seeing the patient is not a question. Looking at the photos may or may not be possible sometimes because you may not have access to photos, but when you see the patient, you get the whole idea. So just look at some of the images of the cases that I was lucky to be part of. This was a 13-year-old patient who presented to us with left thigh so-called vascular malformation, had some kind of surgery done, which was excision, and some kind of embolizations done. So as you can see, the swelling of the left lower extremity, there is a significant amount of venous congestion. On the other side leg, you can see on the axial is much smaller than the left leg. And here on the MIP images, which is maximum intensity projections, huge vascular malformation. And there's such large ectatic venous return. And this is the 3D reconstruction of that image. Now, what do you think this is? Is this the AVM? Is this a venous malformation? What exactly it is? So you cannot put them in one single sort of like category. So this is always like a mixed pattern. But More so, this relies more on the AVM side because, again, the big chunk of vascular malformation is this, which has very huge dilated ectatic vein. So this is the angiogram we performed, and here you can see there's a significant amount of vascular congestion, and there's this huge, which used to be called as nidus, but it's not really a nidus. It's a sac of malformations. Here's some of prior embolizations which somebody had attempted. We did the embolization, and you would notice that this is not just any coil pack. This is a special type of, it's actually a wire. It's called D-cord Benson, where every wire, if you want to be in this field, it's very important to learn how the wires are made and what exactly are the components of the wires. So wires have a core and a mandrel. And when you take out the core, the the wire becomes very floppy and basically is like a spring loaded on the core, which is called as mandrel. So Benson, you can remove the core and it basically becomes a very long coil, which is the cheapest coil available on the market. In fact, Cook company nowadays actually makes a D-cord Benson by itself. And here's post-embolization, and you can see significant amount of decrease in opacification of this the malformation sac. The reason we did this is because this patient presented to us with a heart failure. And this patient actually had a syndrome called P10 hamartoma syndrome, which is a specific kind of a syndrome where you have several AVMs in many different parts of the body. But this was his major complaint. So this heart failure, as you can see, this is 3 months down the line and no more heart failure. So the goal of this treatment was not to get rid of this because it's almost impossible to get rid of this. No matter what kind of procedure you do, no matter what kind of surgery this patient gets, the idea is to decrease the load on the heart because there is early venous return. So there's a significant amount of increased venous return to the right heart, and patients get right heart failure, which eventually leads to the left heart failure. Next patient, we're going to see a 3-year-old patient with a lesion of the left lower extremity. So there is large staining involving the thigh and the calf. And then there's these vesicles. These bleed a lot. It's very difficult to handle them. The best way to image these patients when they present to you, surprisingly, many of the patients do actually end up presenting at this stage. It does not start with small and then grows. It actually does present like this. So no one imaging can give you all kinds of diagnosis, but we kind of know, just a look at it, and you will know this is KTS, which is Klippel-Trenaunay syndrome. You would do CT, MR, ultrasound, angio, any other options. There's many of them, but remember, this is a kid. So we avoid ionizing radiation as much as possible. So we go to MRI, which is our workhorse for pretty much all of these things. And you can see the overgrowth of the limb. There is significant amount of overgrowth. There is ectatic veins, which we will call them marginal veins or sciatic veins, or there's many vein of Saval, and all those names are there. But there is a variety of different things present concurrently in this patient. This is a venous malformation. Is it a lymphatic malformation? Is it an AVM, which usually it's not? This many things come together and form something called as Klippel-Trenaunay syndrome. So this patient has extremities and or trunks which are involved usually, and they have capillary malformations, lymphatic malformations, and venous anomalies which are associated with overgrowth. The lymphatic part, the big giant lymphatics that come with this, is because of the big, huge venous anomalies which need to drain, and that's why venous drainage, when it seeps out, it goes into the lymphatic system, and that's why the lymphatic system grows. It's not the other way around. There is nothing called as veno-lymphatic malformations. Varicosities of the superficial veins, and then hypoplastic or discontinuous deep veins. When you treat them, you have to make sure to do a proper venogram, angiogram, everything. You have to understand if the deep veins are present, because what you would end up doing is start embolizing these anomalous veins and realize that there is no deep veins, so there is no drainage of any venous from that limb, and they may be losing the limb. Orthopedic sequelae is very common, muscle atrophy, contractures, dermal lymphatics, as you saw. These can be treated with many different things: physical therapy, stocking, sclerotherapies, lymphatic macrocyst embolizations. Sirolimus alpelisib is the newer drug which has come for these PIK3CA patients photocoagulation, photovaporization, where you actually take the laser and burn these tissues, and surgical debulking. Marginal veins or ectatic orthotopic veins can lead to PEs and venous thromboembolic diseases. That's why it's important that you do a proper venogram, treat them if there are adequate deep venous system present. 12-year-old female with the left foot pain, do an ultrasound, you see turbulent flow, significantly increased turbulence in the color Doppler, and then this to and fro. Did the angiogram, this is a MRA, early venous return. This is an AVM. Straightforward, single AVM. We did a direct access into the AVM, alcohol embolization, and it was okay. So this is a fast flow malformation. These have usually intervening nidus, which basically is a parenchymal tissue, which leads to formation of this bypass of the capillary bed. That's why they're called as nidus. And then the fistula is that without any intervening capillaries. These are direct non-nidal arteriovenous malformations, which is AVF. They can be acquired or due to penetrating injuries. They can be simple, they can be complex, and treatment is appropriate at the time of diagnosis. Do not wait for the symptoms to develop. Because by the time you have the symptoms, you're going to have a lot more problems to deal with. There are 4 clinical stages of the AVMs: quiescent, expansion, destruction, and high outflow, heart failure. So don't wait for this, because then it becomes a really big problem to deal with. Some simpler way to classify them, there's a Yates classification, Suzuki classification. There's multiple classifications, but Yates is the most common one. There's arteriovenular, arteriovenous, dominant draining vein, multiple dominant draining veins, and simple AVF. The target is the immediate draining vein. You close off the outflow, majority of the time it's well taken care of. Ethanol, remember, there is no ultimate agent which does not exist basically to treat this complex disease. Ethanol is invisible, so non-target injury is very common. Blue is difficult to control, so less penetration. Onyx, excessive occlusion of local vessels, however, less penetration than alcohol. Do not wait for symptoms. Multidisciplinary approach is the way to go for these patients. Some simpler ones, left flank lesion, you do an ultrasound and an MRI, you see this large venous malformation, and you do sclerotherapy. So venous malformations are these sinusoidal spaces, have abnormal endothelial cells. They pool the blood, they cause thrombi, they hurt a lot. They have phleboliths, which is the pathognomonic sign for that, and cause overlying skin to be blue. They progressively enlarge and cause issues, and you can treat them with 3% STS. Nowadays, we are also doing cryoablation of the venous malformations. Remember, they are hyperintense, which is the fluid signal. Phleboliths are always present, which is the drop in the signal on GRE sequences, and they're compressible. Again, one of those venous malformations got access into it, this direct stick, and then embolize them with the glue. This was on the vocal cord. We did a endoscopic approach and then embolized it directly by injecting STS in the venous malformation. And the last one, previously this used to be called as cystic hygromas, not anymore. They're just plain lymphatic malformations. And then do a imaging where you can see the layering hemorrhage within the lymphatic malformation itself, and ultrasound is the mainstay. You do the MRI to see the extent of the disease and treat accordingly. And then these are abnormal developing lymphatic vessels, could be microcystic, macrocystic, or combined. Intralesional bleeding is very common. And then treatment is sclerotherapy, doxy, bleo, STS, alcohol. You choose what you want and what you're comfortable with. These macrocystics can be distinct cysts. Microcystic, in fact, is a very difficult thing to treat, but nowadays we can use bleomycin infiltration, has shown significantly greater response. They have fluid levels. Ultrasonography absolutely is the mainstay of your diagnosis, especially when you're treating. Here you can see the lymphatic malformation. Here's that patient with the lymphatic malformation in the neck. We got access post-treatment. This post-treatment MRI, you can see, is pretty much gone. Some kind of T2 hyperintensities is going to be visible, but that's usually inconsequential. Thank you. I'll take questions.